time to sign off. So Liana, I will screen share, but I'll turn it to you, okay?
Good morning, everybody. Liana Amaya is Maine DHHS. I manage diversity, equity, and inclusion. Lisa, is the screen share up? I don't see it.
I'm just
Okay.
starting it, sorry.
So as in this webinar series, we have covered a number of topics in addressing racial and ethnic disparities. And one of the things that we've been tracking recently is really vaccine equity as we look at how vaccines are being administered throughout the state. And if you have not had an opportunity to take a look, this is the dashboard now currently up on the governor's COVID vaccine website. And we have been daily tracking race and ethnicity of those who have received first and second doses. And we did address this in an earlier webinar. We were noticing a very large number of those in the not provided category initially, of almost at or over 40% of the total vaccinated population. That number is down, which is good news. That number is down. It's still high, however, at about 22% of all vaccinations, still unknown, but it is coming down. So thank you for your efforts within your organizations to really track and submit that data to the state. Some people have asked where you can find ethnicity. It's dropped down within each of the racial categories, and so if you sort of hit the little plus buttons next to each of the racial categories, you'll see how many of those identify as Hispanic and non-Hispanic.
I was going to do that by going live for just a minute.
So we are, what I would also add is that we are starting to see some disparities in the overall rates. We are not seeing our populations of color being vaccinated proportionate yet to their population. And so something to really think about as we're thinking about, as we look at some of the efforts of various providers across the state to really increase that access and the work that we're doing at the state with many of our partners in the community. So for those who haven't seen these are a couple of resources that are circulating both in the community and within the provider community, both about how we ask racial and ethnic data at the clinics, but also general information that is currently available in multiple languages for a multilingual population. And then I would just draw attention to a couple of additional things that have happened recently to support vaccine equity, including Maine's contract to provide free transportation to anyone needing a ride. That contract is through Motive Care. The number you see here is how the individuals need to call and schedule a ride. Just note that they will need to call and schedule a ride 48 hours in advance. It's not great for, the clinic called and they've got a slot right now. It's not going to be the resource for that to run you to a clinic, but if you have a slot, an appointment more than 48 hours out, then you absolutely can use Motive Care for free transportation. Also note that Motive Care will drop off the patient and pick them up in 60 to 90 minutes. And so the clinic should just be made aware because they're going to have to obviously accommodate the patient and during the waiting time. We've also initiated a community vaccination line, understanding that for many, navigating multiple vaccination lines is a challenge. And so the community vaccination line is available with full language services, really focused primarily on those without internet access or who need additional interpreter assistance. Also focused on the homebound and those in need of transportation. So the community's vaccination line can really help to ensure that that we're flagging those who are homebound and need vaccination brought to them, as well as those who need help in getting to vaccination clinics. And then VSafe, which is our application to report adverse effects of the COVID vaccine, has also been translated into a number of languages, though not all the languages primarily spoken in Maine. It's getting to some of them, and is currently available in English, Korean, Chinese, Spanish, and Vietnamese.
Great. So thank you, Liana. And I neglected to also say up front that when I mentioned this is an ongoing series of monthly webinars that we have, in addition to recording, and we'll post these slides that have all those live links in them today, we've posted the recordings and slides from previous webinars onto the CDC website, and I will put the link in shortly as well for that, where those are posted. So we are really pleased today. Last month, we had several members of the community talking about why and how it's very challenging sometimes for members of communities, particularly diverse communities, to either have trust in the vaccine, the healthcare system, or how to access vaccines. So that was, I think, really helpful in building our understanding around that. This month, we thought it would be useful to hear what some vaccination sites, some clinics are actually doing to overcome those barriers and share their best practices and success in those efforts. So I'm really pleased today to note that we have folks from two clinics. So first from B Street Clinic, associated with St. Mary's in Lewiston, we have Modin Mohammed, their cultural broker, and Megan Brewer, their medical director. Additionally, we have from Penobscot Community Healthcare in the Bangor area, Dr. Noah Nesson, Teresa Knowles, the Chief Quality Officer, and Lacey Qualey, RN, who's their Director of Care Coordination. And we're going to hear from each of them successfully. You can put your questions in the chat, but then we'll plan to have at least 15 minutes at the end to have questions and discussion. So with that, I'm going to turn it to Dr. Megan Brewer and Modin Mohammed from B Street Clinic.
Great. Good morning, everyone. Thank you for inviting us to this webinar. We really appreciate it, and we're excited to share what we're doing. Modin, were you able to get connected? Are you on?
Hey guys.
Oh, wonderful. Yeah. Great. We can hear you. Do you want to get started?
Yes. Hi. As Dr. Brewer already said, that my name is Modin, and I work as a cultural broker and an outreach community member for the COVID-19 vaccine. And it has been a great challenge, as we already aware of that this past year. But at the same time, over at CCS B Street, what we've been working was getting ready for the vaccine to equitably distribute it to the community member that needs most. And we've established partners in the community that we are working through to get this vaccine. We are working with the elders and the new Mainers, and we know that there has been some misinformation out there in the new Mainers community and about the vaccine not being safe, and we have worked very hard and to provide the information necessary to give the community that the vaccine is safe, that the vaccine is available to them, and based on the phases that we are doing. There are still those, we are trying and to make them understand, make them educate about them. We are raising awareness about the benefits of the vaccines, and we are taking questions and and the concerns, and we know that, and in the new manners, and we have the religious leaders and the elders, and to provide a factual information about the vaccine. And we have joined with the local healthcare providers, and and we know that when you are in a new place and having difficulty understanding the culture, it is going to be very rough for some of these new Mainers. But what are we doing to make them, understand that the vaccine is safe for everybody? So what we've done was that first, and recently there has been videos where we have in multiple languages, and so that not everyone reads it. I mean, we've provided also a brochure that was written in their language, but not everybody reads it, right? So video will probably make it more easier to get to them and understand from there. We have given them an examples of, what to expect, what to do when you get a vaccine, and where to approach for help. And all that, we put a lot of focus spreading information to counteract the myth about the COVID vaccine. So given the right tools and the right information, we know that people will come around and get the vaccines. It is not any easy when you are new to this country and then all of a sudden that there's this pandemic that you're not aware of in the past, and all of a sudden this is what am I doing? What is going to happen to me or my family if we got caught? So we have to give them the information that at the same time this is a pandemic. It's a serious matter. We have to make them understand. So once they know that the consequence of this pandemic, then they will understand the benefits of the vaccine. So, and we're not mandating everybody to get the vaccine, but however, if we do give them the correct information, people can make an informed decision, whether to get it or not. But in our job is just to educate as much as we can. Recently, CCS, we have able to, established a lot of partners that is, helping get the community information that B Street is in a location in downtown Lewiston urban area where residents feel very comfortable of coming in, even if they don't have a ride. They could just walk. But at the same time, we are able to work other logistics to get people who are in homebound that are not able to come to B Street to seek the vaccine, so that we could work them. We have established, a lot of partners that are trying to advocate people to seek the vaccine, when they can. And recently, with the new Mainers, we've had it, and people that are just, stopping by the office and, asking how can we get the vaccine? Am I eligible? Yes, of course, you are eligible if you are in the category of, the phases that we are doing this month. And what we did was that, and we take their names, we get their information and put on the list. And once, we've reached in their category level, we call them and we schedule them an appointment. And, we are committed to continue, to provide an equitable access. We strategize once we get once we get, how many doses we are getting for this week or, next week, then based on that, and we look at the people that, mostly need it. And we have recently vaccinated Lewiston Housing Authority residents, people the age of 70 and up. And now we are open to vaccinate also the teachers and health workers, and those are the people that are the front lines. We also work with, Dr. Alice Haynes. She is a doctor in the Lewiston community area who also provide us information, people that are seeking to get the vaccine. And we get the list, we put them, and we do a waiting list, and also we waste no vaccine, because in the events that we have people that do not show up on their appointment time, we call those that are mostly needed. For example, people with underlying conditions. Those are the ones that we call, instead of just wasting, but we have not wasted any vaccine so far. And we've had it, I would probably say we had less than 1% of no-show for a vaccine. And pretty much, and that indicates that what we are doing here is, to get this vaccine out, to get the information out. B Street is in a location, downtown Lewiston. We are working very hard, and we want, everybody wants us to live a normal life, and everybody's tired of this, and so do we. What do we want? To get the vaccine out, get the people vaccinated, and the sooner and the better we could do that, and it is the best for everybody, right? And also, but we need to get the resources, the right information to the people. So, if we provide, if we provide a misinformation to the new Mainers, especially new Mainers, we know, they've been through a lot, and it is difficult for them to understand the culture, the Western medicine, and that is our difficult part of convincing people. I have seen people that ask me questions. Did you personally get the vaccine? So, I would tell them, if it was not safe, people will not be getting in this vaccine. We know it is safe, and we want to protect you and your, community member and your families. So that is why it is very important that we work together to provide to provide all the necessary information to be, to fulfill this vaccine equitable. I know that there are some people that are still, hesitant, but it does take some time, and it does take some resources, and it does take a greater outreach. And
Thanks, Modi.
yeah.
Modi's done an incredible job. He's kind of on the front lines for B Street of taking all the calls and organizing with all of our community partnerships to interface with them and make sure that we're getting people in our vaccine schedule. And so to date, we've completed 463 first doses and 263 second doses for folks who would have had a lot of difficulty accessing the vaccine elsewhere. So we're working hard, and Modine is especially key to our efforts. And we're happy to take any questions that anyone has.
I have a quick question. This is Teresa from Penobscot Community Healthcare. What are the specific myths or concerns that you're seeing from the group you're working with in the Lewiston area about the vaccine? Are they unique to other race ethnicities, or are they very similar?
May I, Meg?
Yes, please.
Yes. Well, first, in the community with the new Mainers, and what they believe the vaccine about it is that this, they are saying this vaccine is just to make you sicker, not get better or protect you. What they're saying is that, some of these people are, very attached to their culture and religion. And what they're saying is that, and even pandemic doesn't exist to some of them. That's what they're saying. It's just common cold. That's what they're saying it. And, they think that, this is an experiment that they are trying to do people, the minority, and it is just an experiment vaccine. It is nothing other than that. That's what they believe in. And they also think that, because the reason they think that is the misinformation that was already provided prior to the vaccine. So that is the most issue, that they think it is just an experimental vaccine. It's not, and that's why they don't want to get it.
Modine, I think too, at some point there was some concern about a myth that there was some pork in the vaccine. Do you want to speak on that as well?
Say it again.
I've heard from. Can you speak on the misconception that there is some pork in the vaccine as well?
Oh yes. Yeah, definitely. Whereas others and believe that there is a pork product that are also made it from the vaccine, that they believe, and in their religion is against them to get it. And that is also another issue that they are concerned about, and people of Muslim background, they're concerned about that one too. But we've tried it just to make them understand that, and there's no such things. And where the other things that, this vaccine is just to track you down, or there's a chip in it. There's also things that I have heard on being asked, is it true that this vaccine, has a chip? The government is going to track you down there, just like that. Yeah, things like that is out there. How did it get it? How can we prevent it not to get those information out there? To speak to the community members, to sit down with them, explain to them, or have a provider of a background from their community, as someone that they can trust, then they will listen from them more likely, rather than a member from CCS. They would rather listen their elderly than listen to other members, because if we can make understand the community elders, this vaccine is safe. This vaccine does not have a pork content in it, or any other substance in it other than vaccine. Yeah, we have that missing out there too.
Then Noah has asked from PCHC, is there an opportunity to engage religious leaders from the New Mainers community to help dispel vaccine misinformation? I don't know, Liana, I believe there's been at least some efforts at the state level to have some of those conversations. And then certainly we'd love to hear from any of you. I know, Mohammed Mudin, you just mentioned several efforts from your end to do that, but I might ask Liana to talk just for a minute about what's happened at the state level.
Happy to. So our work group for the equitable distribution and uptake of the COVID-19 vaccine has begun to meet with faith leaders, primarily faith leaders who have large congregations of underrepresented minorities. And so we started that work with Dr. Shaw a couple of weeks ago. I'm actually getting ready to send an invitation for our follow-up meeting, and we're hoping to meet with that group more regularly for this very reason, right? To talk through some of what they're hearing in community and how they can help to be sort of ambassadors for this information around vaccine science and development. But also as we think about helping providers and helping community-based organizations as they're coordinating efforts to get people to vaccination, I think those will be some key partners in that work. The department has also worked similar to what we did with social support services for COVID-19, is working with a number of community-based organizations, more than 24 community-based organizations, which includes ethnic community-based organizations, as well as CAP agencies, Wabanaki Public Health, and a number of others, to contract in support of vaccine efforts as well. And so many of those organizations are working with providers like Bay Straight providers across the state, and they have really close ties within the community. So they're simultaneously working with the faith leaders in their community and other leaders in order to really provide additional outreach and education around the vaccines and to help facilitate access.
Great, and there's a couple of other comments in the responses in the comment section. United Youth Empowerment Services working with a coalition in Lewiston, Auburn to film mayors and religious leaders. So that's an interesting idea, creating brief videos as well. Others, did you want to add, Modine or Meg, anything else on that or otherwise?
Did you have a comment on that, Modine? Filming or doing videos from more of the religious leaders, I think was the question.
Yeah, or just generally how you've engaged religious leaders. And I know you talked a little bit about that already, so.
Okay. Well, I was involved with the New Mainers organizations, and those I advocate on behalf of the community, and at the same time at CCSP, to put the words out there that and we are doing this vaccine right here in B Street. So, and those New Mainers organizations are also able to connect with the religious leaders, and and also those are the ones that we do rely, because we work with them, all these organizations, and we have asked them several times that and they do. We need them to present these efforts and to the congregation, and so that people are aware that we have this vaccine right here in downtown, and where we are located is the center of downtown. And everybody, we have given them the information where they will be able to reach us if they've decided to get the vaccine. And I'm always being available for them, and I've had a great communication with them. They've reached me out several times, and they still do it. And I take the information that and I put them on my waiting list for the vaccine, and they've been doing great job and educating also people on behalf of the community. And they've provided and what they told me was that they were also providing door-to-door information, putting pressure, or and also giving them people where to go, what to do, all those kind of stuff. And they've done so far great, and I've had a lot great inputs from them that they're getting the information.
Great, thank you. All right, well, thank you so much, Modine and Meg, for your work and for sharing that with us today. And with that, we're going to transition over to Penobscot Community Healthcare, PCHC. So Dr. Nesson, Teresa Knowles, Lacey, feel free to take it from here. And I know, Teresa, you have a few slides, and I think you're going to drive on that in terms of sharing, or I think you can do it.
Sure. Noah, did you want to do a brief introduction, and then I'll get the PowerPoint up?
Sure, I'm happy to do that. The good news is I'm going to be brief. You won't have to listen to me talk for very long. I think at PCHC, our approach has been to work to be complementary to the mass vaccination site here in Bangor. We understand the value of that and the opportunity that presents to get large number of people vaccinated quickly. We've viewed our role as being able to complement that by reaching out to people who might not be able to access that resource, and within the age ranges that are our guidance from the state on the use of vaccine, to prioritize the highest risk people in those groups, including people who've experienced healthcare disparities within those age groups. So the important decision that we made early on was to turn this over completely to Teresa and her team and get out of their way. And that's what I'm going to do right now, because they've done remarkable work and have really, Teresa's led this, and her team have just been spectacular in carrying out the effort from my slightly biased perspective. So I'll stop there, Teresa, and let you take over.
Sorry, I planned this out and I've checked a few times and it's up. Lisa, is there any way you can pull the slides up? It's not right handy for some
I
reason.
can. All right, got it ready to go. There you
I
go.
know, I've had it here. I've checked it 5 times prior to.
Well,
Always
we
the way.
don't turn over to Teresa at PCHC as audiovisual management.
Absolutely. So good morning, everyone. As Noah mentioned, our role really has been to supplement what's being done at the MassVac site and to really go where people are. So our approach really has been to vaccinate in place. And so one of our major roles we see ourselves at is targeting the most vulnerable populations that we serve at PCHC. So we're lucky enough, we have a very robust electronic medical record, which allows us to sort of mine very specific data about our patients and to really use that data to focus on those who we know likely have the most challenge getting vaccinated. So on a yearly basis, we've been doing this for a long period of time. We collect race, ethnicity information and enter that data into discrete fields so we can pull that at any time. So prior to, prior to the EUAs being given for Moderna and Pfizer, we had developed a report of all of our 85,000 patients that we've served over the last 3 years. And we break that data out by age, by race, ethnicity, their body mass index, which has been found to be one of the factors that that impacts severity of the illness, any of the chronic conditions that they might have, and you'll see some of those listed here. We pulled those directly from the Maine CDC vaccination plan as the chronic diseases that we wanted to focus on to be able to target people who are the most likely to die or have severe illness. We also, those reports are now updated twice a week. And the first sort of criteria when we run those reports as the priority groups are opened at the state level is for us to pull, so, when it was 90 plus, we would pull 90 plus, and then anyone who identified themselves as being other than white to start with. So we would target those folks first. We would reach out, if we had a small amount of vaccine, we'd reach out first, provide them education, provide them the vaccine, and help them with any social determinants that they might have identified to be able to get in to the clinic. Our outreach is predominantly phone, and we've been doing that with social workers, with a lot of our care managers, and Lacey is one of them on the line that's been doing a fair amount of that work as well. And then if any social determinants were identified, our social workers would help link them to resources in order to get the vaccine. Or like I mentioned, we would go to them. We do know that individuals are more likely to get their vaccine if a trusted healthcare professional recommends it. So one of our best practices, I do this often, and our team has been instructed to do this, is to name drop. So as an example, I would call Lisa Letourneau and say, we have COVID vaccine available. Are you interested in coming? Dr. Nesson asked me to call you and really wants you to come in and get your vaccine. And that works really, really well if they've got a PCP. At this point, about 1 to 2% of our patients seen in our health center are persons of color. And like I mentioned, we reach out to them first. That was one of our priorities, to reach out to them first when a new group was announced. And then we do arrange for interpreters if needed. What we've found, and I've found in doing many of these clinics, folks are naturally bringing their own interpreter with them to get their vaccine, which has been helpful. We also targeted folks who are experiencing homelessness. So we run a shelter with an average daily census, I believe, of about 68. It's up a little bit more now because of winter time. We also have 42 transitional housing units. And so again, with each priority group announced at the state level, we've gone on site to the shelter, to the transitional housing, and have vaccinated in place there, which has been really helpful. We do see sort of a larger percentage of our patients who are experiencing homelessness to be people of color. And so again, very important for us to offer them the vaccine and make it very easy for them to access it. Many of those individuals that we're surveying suffer from severe and persistent mental health conditions, have substance use disorders and untreated trauma. And those individuals it may be harder for them to access a mass vaccination clinic. So for us to be able to go on site and do that is super important to us and has been helpful in getting more of them comfortable with being vaccinated. And again, that group tends to be negatively impacted a lot by social determinants, and so making it easy for them has been helpful. And then I think I've worked with that. We do have navigators in that system as well as social workers, as I mentioned, and they've been doing a lot of work with folks to improve their vaccine confidence and prepare them for their vaccine when they get it. And we're hopeful we'll start getting more Johnson & Johnson vaccine, and we can use that vaccine for this population because they are so mobile, and coming back for their second vaccine might be somewhat challenging. The other group of individuals we've been targeting, and we've done a lot of outreach to and on-site vaccinations, have been persons living in public housing. So we've really worked a lot with the local public housing organizations to go on site, and we've done upwards of 800 vaccines to these folks at this point. So using Penquist Housing, our Old Town Bangor Brewer Public Housing, we've gone on site and done many of them there. What we're hearing from those folks when we're on in the sites there vaccinating, they don't have transportation. Many of them don't have social networks that can help them get to a mass vac site. So they've been very appreciative. And very few actually, even when we drop down to sort of the 70 or 60 range, many of the 70, 80, 90-year-olds still had not been vaccinated, even though their priority group had been announced several weeks prior. Next slide. Homebound patients are another group that we've seen disproportionately impacted here from the work we're doing. So Lacey is on the line, and her team has really been doing the lion's share of this work, where just this week we've been still immunizing 90 and 80-year-olds who just have not been able to get out. So we're doing tons of outreach. I say one of the best practices we did a couple of weeks ago was we took our list that came from the EMR, like I mentioned, and we had a staff person, which was very, very time consuming, but the staff person went into every one of those people's impact vaccine record to see if they received their COVID vaccine, and then reconciled in our EMR. So our report was much more accurate. And now we have a very, very good, robust list of those who are 90 plus and 80 plus and then 70 plus who still are not immunized. So we've been targeting those folks now to go into the homes because most of those individuals just have not been able to get out. It is a less efficient method, as you can imagine. We've put on 877 miles to vaccinate folks in this category. We're basically doing home visits in a 30-mile vicinity around every one of our sites. And again, this is for those who just are frail elderly, or we can't put them in public transportation for whatever reason. And this has been effective. It's been very appreciated by our patients, but like I mentioned, somewhat inefficient. And then I think the other group we've targeted has been elderly housing. So we've gone to group homes and assisted living facilities, long-term care settings. And again, we're not just vaccinating our own patients there. We're vaccinating basically everyone in those settings to get them vaccinated. And from what we've seen so far, very few, particularly in the elderly housing facilities, are refusing their vaccine at this point. So the vast majority of them feel comfortable enough to get their vaccine, which has been great. So I will entertain any questions.
That's fantastic. Thank you so much, Teresa. And we've got a couple of questions in there. I didn't know, also, Lacey, I wanted to give you a chance to add anything in terms of your direct experience with this. Is there anything you wanted to add before we jump into questions?
Yes, I would just say that we are doing a number of home visits. Like Teresa said, we have a number of reports and things like that that we're using to identify patients. We have a lot of our providers that do home visits to homebound patients, and they have sent us lists. We have our transitions of care team that sees patients that are discharged from the hospital and skilled nursing facilities. So we're following those patients and seeing if we can capture any of those populations. We've also worked with St. Joe's Hospital to immunize a lot of their vulnerable population because they don't have vaccine right now. And we've also worked with St. Joe's Home Health to do some of their homebound patients. So it is a huge volume. We've done about 100 home visits since February 4th. And like Teresa said, as far as covering the miles, and I have a team of about 5 people that are alternating those visits. So we still have a number on our list that we will continue to work on. And we've done anywhere from 60-year-olds to 100-year-olds in the home. And we've also captured spouses and caregivers and things like that when we're going into the homes that need vaccine. And we're either able to correlate it at the same time as the home visit, or we're able to schedule them to come into one of our clinics.
It's fantastic.
Lisa,
Gosh, they must be like jumping up in joy to see you show up. That's fantastic. Yeah. I'm sorry, Noah.
I just wanted to add 2 things. Once the Biden administration made the decision to ship vaccine to FQHCs, we were a beneficiary of that, which has helped tremendously. Obviously, we get, I think now 1,200 or 1,300 doses a week from the federal effort, and that's tremendously helpful. And through most of this effort, it's been more challenging recently because the supplies of the syringes and needles we had been using are becoming tighter. But through most of this effort, our pharmacists have been leading the effort at drawing up the vaccines and had reliably been getting 20% more doses than come in the vial. So every vial they were getting 2 extra doses out of. And it got so reliable that Teresa and her team could plan on that. And that had been very important. I think we shared our secret sauce in that, and then the supplies became more difficult to obtain. But those 2 things have been critical to this effort.
So that's a great point. And I see the question in the chat that says, has vaccine supply not been an issue for these 2 sites? And, I think it has in the past. It's a little better lately, although Noah, Teresa was sharing, you guys haven't got this week. So it is still this ongoing challenge, right, of what are we going to get? I think B Street has received some directly from the state supply. And I just wanted to acknowledge that it's been incredibly frustrating. And I'm sure as people hear these great stories, they're like, yeah, but we don't have vaccine. So, what we've experienced is this initial supply, we thought it was going to go up dramatically. J&J came on board. We got our first good supply for 1 week, and then literally like dribs and drabs, and then none for 1 week. But we keep hearing from the feds that we are about to have the floodgates open and start getting more substantially beginning in April. And I know that there is a real desire on the part of the state to distribute that vaccine much more widely once that becomes available, including to primary care and more primary care offices. What Noah and Teresa have talked about is this direct supply from HRSA, the federal agency, to right now it's just 2 FQHCs. It's supposed to be 4 more, and then ideally more, but we know that's been an issue. But I think, for this, the people on this call really thinking ahead to April's not that far away, right? It's a couple of weeks. So, geez, do you have those systems in place, like Teresa just described, to identify people at highest risks? Do you have any possibility of getting out to more vulnerable populations or to homebound? Because it's going to take some time if people don't have that in place, right, to ramp up those systems. So I know it's been a hard slog, and hearing us say, when we have more, but we really do think we're going to have more beginning in April. And then again, once we go to the all ages in May, there'll be, certainly more populations eligible as well. So hold on, we hear it's coming, hopefully sometime soon. Other questions for this great group here. I'm trying to see if there's another one. One here is, how are you tracking homeless whom you vaccinate on site so that you're able to get them a second vaccine, assuming you don't have J&J?
We've really left that to our homeless shelter staff and our navigators, like I had mentioned earlier. So we're trying to stay in contact with them for the full 4 weeks to make sure we have good information and we have a contact number for them. So far, we've had, I believe, we just dropped to 60, so they have not received their second dose. They just got that, I believe, a week or 2 ago. And we only had sort of a handful of people who were 70 plus, I believe 5 of them, and 1 had moved to the Portland area. So 4 got their second dose and 1 did not. So far, again, small numbers, but so far that's worked out okay. And that's sort of why we're hoping the Johnson & Johnson vaccine becomes more available, because we can give them that 1 dose and then won't have to worry if they are moving more frequently around the state.
At B Street, we've partnered with the Lewiston Wellness Lewiston Wellness Shelter, working with Community Concepts to schedule guests of the Ramada Inn Shelter. And so Megan Parks through Community Concepts has been really instrumental. And so she's helping us to connect people back for that second vaccine and kind of tracking that. So for us, it's been primarily community partnerships.
Great, thank you. Other questions, and again, feel free to use the chat or just to unmute and ask questions. I'll tee up one more, and this might be more for PCHC, although I'm sure, Megan, you must have some patients that live in more rural areas, but we read a lot about vaccine hesitancy. We've been talking a lot about vulnerable populations, diverse populations, but rural is also a giant issue of disparity and vaccine hesitancy that we're seeing emerge more and more out of the national data. And I'm wondering you've talked about 848 miles. I know you're driving a long way, but are there any particular strategies either to build vaccine confidence, or is that something you're encountering in terms of more resistance from people in more rural areas? And what are you hearing, seeing, and what are you doing to address some of those challenges?
I think some of what we have read that that folks in rural areas tend to have more vaccine confidence if they're getting it from their PCP. So some of our strategy has been to go on site. So as an example, we have a site in Jackman. So we brought vaccine to Jackman and held a clinic there so that they're seeing their PCP, they're seeing their same clinic staff. We've done the same thing in our Belfast practice, our Old Town practice, the homeless shelter practice that I mentioned. So we're trying to hold many clinics there so that they're they're actually seeing the same familiar faces, the same check-in people, their PCPs, and have them sort of wander through the clinic, just saying hello to folks, and that has been more successful. No, I'm not sure if there are any other ideas that you have as well.
Well, Lisa Letourneau has organized a speakers bureau of people to do outreach or to do talks for populations of people, hopefully affinity groups. And we've done public events to Facebook Live events to try and answer people's questions and address concerns about the vaccine. It's hard to measure how much impact that's had. And my personal experience with those is it attracts like the people who are just barely on the vaccine hesitancy side of the meter, who just need a slight nudge to go over to the other side, and probably not the people who are really significantly vaccine resistant. So I don't think we've had any other, more specific outreach than that, or any other brilliant ideas on how to best do that, except through trusted relationships. I mean, the real answer in all of these kind of circumstances is relationship. And if you can take advantage of relationships, as we discussed, in the context of B Street, with the religious leaders, with community leaders, with their trusted practices and other partners in rural areas, that's probably the best approach, and making it as convenient as possible.
That was one other thing. We have reached out over the last couple of weeks to faith-based organizations to see if they'd be willing, in May, when it's open to basically everyone, if they'd be willing to hold vaccine clinics there if we get enough vaccine. And we have had some folks take us up on that offer. So again, the idea would be to go and vaccinate where they feel safe, where they have trusted individuals and other people that can support them in getting their vaccines. So we've done a little bit of that outreach. And then I would say the other thing, NOAA's been doing a ton of educational series with our patients and with our staff and with others. That's been helpful. And then we set up our pharmacists. We have some pharmacists within our organization who can answer specific questions about the vaccine. So what we're seeing sometimes, I would say most times, people have generic questions about the vaccine, but then also very specific questions about the vaccine and how it relates to them personally and how it relates to them physically with, medications that they might be on or infusions that they might be getting. So they just want someone to give them sort of more evidence or more information about how the vaccine impacts them directly. So we have sort of a direct line to our pharmacists. So if someone calls or reaches out or emails, we put them in touch with the pharmacist who can sort of go through that information. So that's been helpful as well.
Terrific. Thank you. I also just put in the chat, I had already teed up the link for, we're going to continue this discussion in April. So I've got the link to register in advance, or the link that you used for today. Then also Noah mentioned that we've got more than 30 very ambitious, eager clinicians who are agreed to be part of this COVID vaccine speakers bureau that could be tapped into to join community conversations, say with, a church group, a Rotary Club, a workplace. So the request form, I put the link in there. There's another question about ways to incorporate volunteers. Do you have ways to incorporate volunteers from outside your organizations in these outreach efforts, particularly for reaching homebound or more rural clients? Either one of you have any thoughts about that?
Megan, did you have any anything you'd like to add? I can jump in when you're done.
Yeah, I think that is one of the areas that we need to start paying more attention to and expand. I know there is some community partnerships with the Androscoggin Home Health, although I've had 2 homebound patients this week that we've tried to connect through them, and they they don't have the capacity right now. So I think that's where we need to start focusing on maybe shifting efforts a bit. We've mostly focused on the immediate downtown community.
I would say for PCHC, we've been using a lot of student nurses from the University of Maine, predominantly since the beginning of the pandemic. So I would say at any given time, we probably have 7 student nurses a week that are helping us immunize, which has been really helpful. We wouldn't have been able to do it without them. We also have other volunteers in the community that want to come in and help with more of the administrative work. And we've taken them up on that offer as well. Right now, we have not used many volunteers to do homebound vaccinations, mostly because we either need nurses or medical assistants to do that work, and we haven't found a ton of nurses or medical assistants who are volunteering their time outside of work. So right now, we're using our own employed staff for that, but would welcome any volunteers.
Great. And then I'll just certainly put a plug in for the Maine Response System. That is the statewide system for registering for volunteers. I know it's been a little frustrating because people have signed up a while ago. We haven't tapped into them, but they are starting to tap into volunteers. Actually, one in the Lewiston area for the larger site there. And I believe organizations can actually sign up to then use volunteers from Maine Response, but I'm not the best on the details of that. If anybody wants to volunteer, broadly in vaccination efforts, I can put the link in too, but signing up through Maine Response is a great way to go. They do background checks and the state provides liability coverage in that setting. Anything else? Other questions? Not seeing others in the chat. Anybody want to jump in with a question? All right. Well, with that, we will probably wrap up. I'll just remind everybody that we do post these sessions on the CDC website, which I actually was to put the link in, so I will do that shortly. But thank you so much to our presenters from B Street, PCHC. You guys are doing fantastic work. And Liana, I'll turn it back to you to close while I put the link in.
Thank you to our guests so much for joining us today, and to all of you who took time bright and early this morning to be with us. Just as a friendly reminder to please remember again to continue to collect race and ethnicity data, and to continue to make sure that you're reporting that into the state. Again, it's always hard for us to really track progress and identify gaps if we don't have that information. So I'll continue to put that plug in every single time. But we look forward to sharing additional best practices in future meetings. So thank you so much to all who joined us.
Great. And so that we are still holding these the third Wednesday of each month. So we'll be back on April 20th, I believe it is. For those who have not, April 21st, sorry. And we'll be continuing to share some of these best practices. So thanks everybody again for joining. Thank you, Noah, Teresa, Lacey, Modine, and Megan for the great work again that you're doing and for sharing that with us today. Take care, everyone. Bye-bye.